going to start off with some questions. I see Rena there. Is Dr. Soffer on the line? Well, maybe we'll start with a question for Rena first. So I think it's kind of conventional wisdom, or at least Michael Vasey conventional wisdom, that for a PPI non-responder with quote unquote typical GERD symptoms who fails a PPI twice a day, that the yield of physiologic testing is quite low. So I wondered, in your study, what percentage of the patient population that you had, which is probably a tertiary care population, so a little bit different than what we may see in practice, but what percentage actually had acid exposure over the course of 2 days and thus were candidates for maybe a PCAB or some other form of anti-acid therapy? I think you're muted. Sorry, Rena, I think you're muted.
Okay, thank you for unmuting me. Hi, thanks for that question. So yes, right, we had 100 patients in this clinical trial. They were enrolled at 2 tertiary care centers, and about 55% of them had at least 2 days or more with an elevated acid exposure. Part of the trial that we're continuing to follow is they were escalated on their anti-reflux management. So either baclofen was added to their regimen. Some of them did undergo anti-reflux intervention for PPI non-responsive GERD, but a significant portion did have essentially normal physiologic findings on their wireless pH monitoring.
I'm sorry, did you say 55% though didn't?
55% had elevated acid exposure for 2 or more days.
Wow, okay, very good. And you think that that wasn't just a compliance issue, that was real?
Yeah, so this was wireless pH testing off their PPI therapy. So these were patients that had reflux symptoms but were not responding to single dose PPI, and then underwent wireless pH off their PPI for at least a week. So we weren't surprised that a good majority of patients did have pathologic GERD, but at the same time, a good proportion did not have pathologic GERD. And I think that's a very important message of the study.
We have a question that may be better suited to the next set of speakers, but I'll just throw it out there for both of you as you see these patients. So after a successful myotomy, meaning physiologically successful, there are patients who still have the symptom of dysphagia, and whether that's attributed to a peristalsis or something else, it can be difficult to treat. So what kind of evaluation and management strategies do you suggest?
I can start. So these patients are extremely challenging. I think first of all, you want to make sure that they have had a complete myotomy, and you want to do your due diligence in ensuring that they don't require any other intervention, because pneumatic dilation, POEM, or a redo Heller can significantly help those patients. But if they had like end-stage achalasia type physiology to begin with, they may have ongoing symptoms. We usually recommend lifestyle modifications. Typically, we reserve esophagectomy for really few select patients. And some of our foregut surgeons have done surgical interventions to straighten out the esophagus. I've had a couple patients undergo this, so you might want to discuss with your surgeon as well.
Okay. These are questions are very difficult, but so LPR, quote unquote LPR, without response to PPI, what is your approach to management? Maybe Dr. Soffer, just.
Yeah. So, you can start with treatment. And first about different types of LPR. I mean, you can have dysphonia, you can have cough, and the studies that were done address different symptoms. More studies done on cough than, let's say, dysphonia or asthma. But you can start by treatment with PPI. This is, by the way, by some of the authors that published plenty on this topic, is considered as an important predictor of success of surgery if you are going to go the way of surgery. And after that, you really want to assess whether the patient has reflux to begin with. And so assessment of status of esophageal reflux exposure is going to be essential. Beyond that, And if the patient did not respond, if the patient responds to PPI, if the patient has abnormal acid exposure, and if you throw in other features such as a large hernia, this is a setup of patients that have a higher possibility or probability of response to surgery. But this is a topic that is confusing, lack of controlled trial, prospective studies. So you go by your experience and whatever retrospective data you have.
Very good. Very difficult topic. I agree. So another question, which again may be more for the interventional endoscopist, but perhaps you guys know the literature well enough to answer this. So there was one study presented comparing the anterior and the posterior approach for POEM. And then, of course, studies about avoiding the gastric sling fibers. So would there be a theoretical advantage to the anterior approach if you're trying to avoid the sling fibers? And was that take into account in those studies?
Sure, yeah, I had presented that abstract of the anterior versus posterior approach. So, you know, what I have found with advanced endoscopists that actually perform POEM, that it's a very endoscopist specific preference, whether they prefer the anterior versus posterior, and also depending on the patient. So if they've had previous interventions and fibrosis, their proximity to cardiac structures, pooling of liquid depending on the anterior versus posterior. So those are some things that endoscopists have told me guide their selection of therapy. But I don't think that the anterior approach has taken into effect the sling fibers.
Okay. One other question. Which neuromodulator do you prefer for PPI non-responders? First line therapy.
This study looked at antidepressants, either tricyclic or SSRIs. The SSRIs appear to be to have better response than tricyclics, but I think both can be tried depending on patient tolerance.
Fantastic. We're right on time. Thank you both for a great session. We're going to move on to interventional endoscopy, and Eric is going to introduce the first speaker.
Thank you so much, and thank you, Dr. Soffer, Dr. Yadlapati. It's excellent. It's great to see you both.